Okay, then shall we start? So, thank you very much for attending this session, APSC-JCS Joint Symposium focusing on MitraClip. I'm Takashi Matsumoto from Sendai Kousei Hospital. I will share this session with Dr. Khung Yeo from Singapore National Heart Center. And we have, in this session, we have 4 presentations. One is from me, and the second one is from KK. And the third one is from Dr. Shirai. He is from Department of Cardiology, Kokura Memorial Hospital. And the final presentation is from Dr. Izumi. He is from Department of Cardiology, Sakakibara Heart Institute. So then let's start our presentation, KK.
So thanks very much, Takashi. It's a great pleasure to be here at the APSC-JCS Joint Symposium in the JCS Annual Scientific Meeting. Our first speaker is Dr. Takashi Matsumoto, who needs no introduction. He's from the Sendai Kousei Hospital, and he'll be giving us a talk on the APSC MitraClip consensus document. Over to you, Takashi.
Thank you. So could you share my COI slide? So I don't have any conflict of interest for this presentation. And then could you start my recorded presentation? I'm Takashi Matsumoto from Sendai Kousei Hospital. I'm very honored to be here and present Asian Pacific Society of Cardiology consensus statement on the use of MitraClip for mitral regurgitation. Next two slides shows expert panel members. Chair of this statement is Dr. Khung Yeo, and I and Dr. Jack is co-chair of this statement. And as you can see here, expert panel members include interventional cardiologist, the cardiothoracic surgeon, echocardiographer, and also heart failure specialist. This slide is method, consensus building, evidence grading. We have 4 grades: high, moderate, low, and very low. The consensus building by a online pooling, agree, neutral, disagree. Level of consensus. Cutoff for consensus, 80% agree or neutral, and percent agree, neutral, disagree, reported separately in each statement. This slide shows a schematic diagram for mitral regurgitation. Important point of this slide is cutoff for severe MR. It's defined as it's defined as EROA equal or over 0.4 centimeter square. It's the same as American Society of Echocardiography. The MitraClip used in degenerative mitral regurgitation, DMR. We have 3 statements. Statement 1, both symptomatic and asymptomatic patients with equal or over 3 plus DMR who meet the indication for surgery but are considered high risk by heart team should be considered for MitraClip implantation. Level of evidence is moderate, agree 80%, neutral 16%, disagree 4%. And statement 2, MitraClip use should be considered for symptomatic high risk equal or over 3 plus DMR patient with or without reduced LVEF. It's moderate level of evidence, agree 84%, neutral 12%, disagree 4%. Then statement 3, MitraClip use may be considered for symptomatic patient with high risk equal or over 3 plus DMR with reduced EF and or LV dilatation or new onset AFib or pulmonary hypertension. Low level of evidence, agree 84%, neutral 16%. Here we selected word very carefully. First 2 statements we used should, and the third one we used maybe. The MitraClip use in functional mitral regurgitation. Statement 4. MitraClip should be considered for symptomatic functional MR patient who are already on GDMT. Functional MR patient should receive at least 1 month of optimized GDMT with reasonable attempt to up-titrate treatment as well as CRTD if indicated before being evaluated for further intervention for or MitraClip use. High level of evidence, agree 88%, neutral 8%, dissent 4%. This statement 4 is based on a result of COAPT trial. It is recommended as Class 2A indication in HACC Guideline 2020. Then statement 5 is for ischemic functional MR, coronary anatomy and ischemia evaluation should be performed before MitraClip consideration. If PCI is performed, staged MitraClip therapy should be considered for severe symptomatic functional MR. Ischemic functional MR patient requiring CABG for revascularization, concomitant surgical mitral valve repair or replacement may be considered. Low level of evidence, agree 100%. Then statement 6. Functional MR patients should be monitored regularly and referred early to the heart team for potential MitraClip implantation. Discussion and endorsement of utility should be deferred to the heart team. Low level of evidence, agree 100%. Then statement 7. Symptomatic patient with equal or over 3 plus functional MR should be assessed by the heart team for possible MitraClip implantation. Higher level of evidence, agree 100%. And then statement 8. Functional MR patient who do not meet the eligibility criteria for MitraClip implantation, it means too early for MitraClip, should be closely monitored. These patients should be considered for MitraClip implantation once eligibility criteria are met. So this statement 6 to 8 is very it's very important when we see a patient with functional MR patient. So when we see these patients, always we need to consider potential indication of MitraClip. Then we can treat those patients at optimal stage and avoid too late stage for MitraClip implantation. Then this slide shows technical considerations for MitraClip use. We have 3 groups: ideal, complex, and inappropriate. Ideal has pathology in segment 2. It's center jet and valve area over 4 cm square. Then complex group, pathology in segment 1 or 3 from lateral or medial jet. Then short posterior leaflet, it's defined under 7 mm. Barrow's syndrome, the cleft, severe calcification, prior annuloplasty, rheumatic leaflet thickening. Inappropriate group, leaflet perforation, active infective endocarditis, moderate to severe mitral stenosis, then left atrial thrombus. This slide is a flowchart assessment and initial management of patient with functional MR. When we see functional MR, its severity equal or over 3 plus, then we need to evaluate coronary artery anatomy and ischemia, and we need to consider revascularization if it's needed. Then heart failure specialist need to optimize GDMT plus minus CRTD. Then even after this GDMT, the functional MR persists its severity equal or over 3 plus, then re-evaluation by echocardiogram is needed to be attempted. Then T for defining etiology and transthoracic for assessing severity. Then refer to the team for MitraClip indication. Subgroups and special populations for MitraClip: atrial FMR, concomitant MRTR, acute MR, and HOCM. Statement 9. Patient with symptomatic atrial functional MR should be evaluated by heart team and if treatment has already been optimized, MitraClip may be considered. Low level of evidence, agree 96%, disagree 4%. Statement 10, the expert panel acknowledged that MitraClip has been used in less common scenario, acute MR, dynamic MR, HOCM, and TR with reasonable reports of clinical success. However, enrollment in the clinical trial or registry is preferred. Patients with these less common conditions should be evaluated by her team on per patient bias with informed patient consent on the limited understanding available to determine whether MitraClip use would be feasible and beneficial for them. Low level of evidence, but agree 100%. This is final slide. Thank you very much for your attention, and also thank you very much for all of the panel members who built this statement. Thank you very much.
Thanks very much, Takashi, for sharing on the APSC MitraClip consensus document. I maybe just want to get the discussion going and ask, our colleagues in the panel, whether they have they had a chance to look at the, looking at the presentation. Were there any areas that they had comments on that maybe we are not strict enough or we are too lax in terms of the guidelines?
So from my opinion, I think this is a very reasonable statement. Of course, this statement is different from a guideline, but this statement is very based on daily practice, I think. Is there any comment from Dr. Shirai or Dr. Izumi?
Thank you very much, Dr. Takashi. So I really agree with the agreement of the APSC. So I have one question though. Okay, so in FMR, in some patient is candidate for the Elvado and the cardiac transplantations. And so how about the criteria to determine which is the MitraClip or the next step transplantation treatment for the functional MR?
Thank you very much. And this is a very difficult question. So maybe no one knows correct answer.
Yeah.
So yes, of course, ventricular FMR is good indication of MitraClip when we see the result of COAPT trial. But when we treat a very young patient under 50 or 60 years old, we always need to consider Elvado or heart transplant. But which treatment, BAD or heart transplant or MitraClip is better for for patients? It is very difficult to decide. So how about the situation in Singapore, KK?
I think it's a very difficult situation because for heart transplant and for LVAD, there are a lot of other considerations. I would say that for LVAD, for heart transplant, the biggest issue is the availability of the donor heart. And for LVAD, the biggest issue is actually cost. I think even though the MitraClip procedure is expensive in our country, it is still more affordable than LVAD. And LVAD, I think, has other consequences as well. So I think if you were to ask me, I think it is important to catch hold of these patients before they deteriorate to the point that only an LVAD or heart transplant works. But of course, by the time that only an LVAD or heart transplant works, then we should go ahead and do it. We have had, I think, one patient that we put in an MitraClip. The MitraClip worked, but the patient still had to undergo an LVAD, within 6 months. So I think it's got to do with patient selection and recognition by physicians that the clip is a viable option for functional MR patients.
Yeah, I agree. But important point is when we see at these young patients, we always need to consider the indication of heart transplant and ER, but before we treat with mitral valve surgery or MitraClip. So, and important point of this statement is when we see patient with functional MR, it is a little bit early for MitraClip. At, at this, when we see those patients, we need to consider, always consider the potential indication of MitraClip. Then we send those patients for MitraClip at optimal stage and to avoid a late stage, too late for MitraClip. So I recommend when we some always we need to consider MitraClip indication. Yeah.
I think you're right. The value of a consensus document is that it puts it out into the general public and to the other cardiologists in our profession, so that they are aware that this is now available. I really thought this our literature in the Pacific.
Is there any comment from Dr. Izumi?
Oh, thank you, Dr. Matsu. I have another question. Okay.
Yes.
Do you consider an experience of an operator or institution for case selection? Because the increasing institution experience is associated with improvement in treatment and improvement in procedural technique or intraoperative imaging expand the indication of CLIP.
Yes, that is also a very important point. So we need to always consider a learning curve. So in this statement has a one slide for technical consideration. It has three groups: optimal and complex and inappropriate. So in each institute, when we start MitraClip program, I recommend to treat that appropriate patient.
Thank you.
That is very important, I think.
So I guess, shall I go to my talk?
Yeah. So go to second presentation. The second presenter is Dr. K.K. Yeo from National Heart Center Singapore. And his presentation is update on latest data on MitraClip.
Thanks very much, Takashi, and it is my pleasure to be here at the JCS meeting here at the APSC-JCS Joint Symposium. These are my declarations of conflicts. Well, back a year ago in January 2020, the word COVID was not even coined. But by then, there had been more than 100,000 cases of MitraClip already. And in Japan, the MitraClip deployment has been well underway. And globally, the XTR experience has been growing. The MitraClip technology has since evolved. We now have in many of our respective countries, including Japan and Singapore, the G4 platform, which I will describe in greater detail. But this slide here shows the evolution of the MitraClip device, and you can see the various enhancements over the years. What is important for the G4 is that it's got wider clip arms, 4 clip sizes, and there is controlled gripper actuation and continuous left atrial pressure monitoring. Importantly, the prior generation had the XT version, which has an additional length of 5 millimeters in terms of the clip arms. I want to talk a little bit on primary MR now, and these data are from presented at ACC 2020 by Scotland. This is for degenerative MR, although the larger EXPAND registry has both functional as well as degenerative MR. So for this set of slides on primary MR, there were 422 patients, and we had, or rather there was an independent physician committee for single leaflet detachment and leaflet injury cases. Just to remind everyone, the NTR is 9 millimeter for the clip arm, and the XTR is 12 millimeter, and it had a superior delivery system. The main findings are shown in this slide. You can see in comparison to the original Everest prohibitive risk primary MR group, as well as the TVT registry, the EXPAND primary MR study, which is a global registry, had excellent implant rate of more than 99.5% and acute procedural success of 94.5%. You can see that we've experienced the fluoroscopy time, procedural time, as well as the length of stay had improved. And in the EXPAND primary MR registry, it was only 1 day in the United States. The ECHO COAPT adjudicated mitral valve complexity shows that up to 29% of these patients had complex mitral valve anatomy as according to the criteria you see on screen. That is primary jet outside the A2P2 segment, presence of more than one significant jet, presence of an extremely wide jet, small valve calcification, minimal leaflet tissue, or the presence of severely degenerative leaflets or wide flail gaps. What the results of this study show is that if you can look at this slide, the MR reduction was really quite impressive. Looking at the set of table, the panel on the left side, you can see that the MR reduction to less than or equal to 2 plus was 96, close to 96% in the EXPAND registry, and this is in comparison to 82% in the Everest and Realism prohibitive risk group. This suggests that with clinical experience, the results, the MR reduction has improved dramatically. And bear in mind that these are patients with not just basic anatomy, but also complex anatomy. And this is with the same echo COAPT and same methodology. So the other key findings from the EXPAND registry are shown here. First, the single leaflet detachment rates were approximately 1.9%, and leaflet injury or tear was seen in only 0.2%. As mentioned, approximately 1/3 of patients had a complex mitral valve anatomy, and that the EXPAND registry showed that MR of less than or equal to 1 plus was achieved more often with the NTR and XTR than previously observed in the Everest 2 trials. The XTR was associated with greater MR reduction compared to NTR in more complex anatomies, but most importantly, it is that the NTR and XTR systems were safe and effective in real-world practice. So this is the G4 system, as I mentioned earlier on. Just to highlight the key differences, first look at the figure on the right side of the screen. The NTW, the wide system, had a 50% grasping area in the middle to proximal segment of the clip, whereas for the XTW, it is longer, and as mentioned, it is 3 millimeters longer in terms of the clip arms. So we have early experience with the device, and I think that the NTW and the XTW, probably more the NTW, will be the likely workhorses. The length of leaflet is important in terms of device selection, and the NT system is preferred when we are doing the procedure near the commissures. XT system has a somewhat greater risk if we are dealing with perpendicularity issues. So we have to be very careful using the XT system and in terms of perpendicularity. There's a trial coming up that is ongoing, and that is the Repair MR trial, which will further inform us as to the use of the MitraClip in patients with moderate surgical risk in primary MR. So this is ongoing. 500 patients will be enrolled in up to 60 sites. You can see that the principal investigators are Pat McCarthy from Northwestern and Saibal Kar from California. Echo COAPT at the MedStar Washington University Hospital. The core primary endpoints are shown. The first core primary endpoint is all-cause mortality, stroke, cardiac hospitalization, or acute kidney injury requiring renal replacement therapy at 2 years. The core primary endpoint, number 2, is the proportion of patients with moderate or less MR without mitral valve replacement and without recurrent mitral valve intervention from the time of index procedures through to 2 years. So these are really important endpoints for us to consider in the for degenerative MR. I'd like to move on to FMR. These are data from 2018, 2019, so I won't dwell too much in it, except to say that MitraFR did not show any additional benefits from using the MitraClip. But the COAPT trial, we well know, has a superior effects in patients with functional MR. And here the primary effectiveness endpoint with a number needed to treat of 3.1, and an all-cause mortality reduction of with a number needed to treat of 5.9. So very impressive results from the COAPT study. And I want to highlight the fact that the MitraClip in the COAPT study had such a dramatic percent decrease in mortality in relation when compared to other drugs that we are familiar with, such as Entresto or beta blockers. So in the COAPT study, I think the key finding and the key important point is that it helps us understand the concept of proportionate and disproportionate MR. And essentially, in patients with LV systolic dysfunction, the effective regurgitant orifice area must be interpreted in context of the end diastolic volume. And so this slide, which I think all of us are familiar with, highlights the difference between the COAPT and MITRA-FR study in terms of where the patient selections were. Now, what is important is that I think this is just a couple of last week or the week before where the 3-year data was published and in JAC, and you can see that the results are durable up to 3 years and beyond, and even for patients who cross over, whether it is all-cause mortality, cumulative heart failure hospitalization, or a combination of these indices, the MitraClip therapy remains durable in treating functional MR patients in the COAPT study. There was a study that was published earlier this year that looked at COAPT-like profile, and this is out of 3 European sites. And essentially, if they look at patients who were COAPT-like, those who were COAPT-like are more likely to have a benefit. I think the money slide is on where my arrow is pointing. You can see compared to non-COAPT patients, those in red, which is the COAPT-like profile, had superior outcomes in terms of freedom from all-cause death, or freedom from cardiovascular death, or heart failure hospitalization. The criteria for COAPT-like profile is shown on the table 1, which is that all the following criteria should be met. Now, I won't read this out, but these are well known to all of us from the COAPT study. I want to highlight another important study that was just published, and that is the relationship of right ventricular dysfunction on outcomes after MitraClip therapy for second. And this is from the European registry, 817 patients, and they use this particular measure called RVPA coupling as measured by TAPC and SPEP ratio. So if you look at right ventricular dysfunction, those with normal coupling did better than those with impaired coupling, which I think is an important additional piece of information as we learn how to choose patients with functional MR that might benefit from the MitraClip. So I want to highlight that because this is a new development in just barely the last year. And lastly, I want to talk about the use of the MitraClip in cardiogenic shock. So here are some of the key findings, and essentially across about 122 patients, the MitraClip, when used in patients with cardiogenic shock, had a mortality rate of about 22%. But bear in mind that these are all comers, including 75% functional MR patients. So this remains a very difficult group of patients to treat, but clearly it can be used if in selected patients. So in summary, the MitraClip therapy is safe and effective in degenerative MR, as shown by the EXPAND registry. With the G4 device, there are more treatment options, and we are eagerly awaiting the results of the REPAIR MR trial. For functional secondary MR, we continue to learn from the COAPT study, and I think there's much more to learn in terms of patient selection. And with that, thank you very much.
Thank you very much, KK, for very systematic and educational presentation. Is there any comment or question from panel? Then, so can I ask one question, KK? So G3 and G4 has a long arm clip, right?
Yes.
So do you use these long arm clip as a first line or second line? Because our patient is Asian population has a little bit small heart, so we always needed to consider. I think we always needed to consider injury of mitral valve.
You're right. The long arm clip, the XT version, makes me a bit more nervous because there's always the concern that the additional pooling of the leaflet might result in leaflet tear. But I think there are definitely situations where I would use it. In fact, I used it just last week in a case where there was a loss of primary and secondary caudal support in a very flail leaflet, and there was a hinge point which I wanted to cover. So I used an XT-W in that case successfully. So I do think that it's probably something we would have to choose very carefully in which patients to use. I think the other situation which I might want to use it is in patients with Barlow's or Barlow's-like leaflets. Those would be another group of patients. But otherwise, it is not my go-to clip. My go-to clip is the NTW currently.
Okay, thank you. Same, I agree with your idea. And about the COAPT trial, so when we treat a patient like a COAPT-like patient, then we can achieve we can reduce the mortality and reduce the rate of heart failure admission. I agree, but sometimes when we see patient with severe functional MR, but very low ejection fraction or very large LV, so how do you treat those patients? Do you apply MitraClip or just follow with GDMT?
Well, for me, I would consider offering the MitraClip. I think the numbers are indicative measures, but by themselves, they are not hard stops for me. At least in Singapore, we are allowed to. And for LVEF measurements, there is a substantial variability depending on loading conditions and other factors. So I would say that I tend to allow myself, or we as a team we do discuss this. If the patient has end organ damage and the EF is very poor and the LV is very large, then maybe it's better suited for heart transplant. But if they can generate a good pressure, I think it's still worth considering.
I see. Thank you. Is there any question from panel? So how about Dr. Izumi? Do you have any question? It's mute.
Yes, I think the timing of intervention is very important for FMR. So because two remodeling LV and has gone an adverse event, many. So not too late for a MitraClip, I think.
Yes, I agree. So ideally, we should treat at optimal stage like COAPT-like patient, but sometimes when we see too advanced stage, but even though if the severity of MR is severe for sure, then I think we can achieve some symptom relief for improve a QOL, I think. Okay.
Yeah, I agree. I agree with you, Takashi. And with that, maybe it's a good time to see what the Japanese experience is with the MitraClip. So it's my pleasure to now invite Dr. Shin-ichi Shirai from Fukuoka to on his talk on the Japanese experience with the MitraClip. Over to you, Dr. Shirai.
Okay, thank you very much. So thank you everyone. I'm very honored to present today. So this presentation is clinical outcomes of 1-year Japan PMS study for high surgical risk patient with moderate to severe and severe mitral regurgitation. This is my COI. So the MitraClip is a transcatheter mitral valve repair system, and 100,000 patients would receive the procedures all over the world. The AVJ trial, which was approved trial in Japan 2015, demonstrated the efficacy and safety of MitraClip for the patient with high surgical risks. According to the excellent result of this trial, MitraClip was approved in 2017 in Japan. This Japan PMS was launched to monitor safety and efficacy of MitraClip and evaluate its real-world clinical outcomes in Japan. The footsteps of MitraClip. First in man of the MitraClip was performed in 2003 in Europe, and then CE mark approval was obtained in 2008. In US, FDA approval at first only for the patient with DMR, and according to the result of the COAPT trial, the FDA approved the indication for functional MR. In Japan, it took a long time, and later in the US and EU and other Asian countries for launching the MitraClip until 2018. However, the indications were both DMR and FMR earlier than US indication. So we greatly appreciate to the 40 sites PMS investigated to present this report. The method of this trial, the design of the prospective multi-center single-arm surveillance study that enrolled 500 patients across 40 Japanese sites between April 2018 and January 2019. Key outcome measures were site-assessed, intention to treat analysis, MR severity, procedural outcome, MAE, survival and hospitalization, and an NYHA functional class assessment. Primary endpoints were a site-reported single leaflet device attachment SLD rate at 30 days and acute procedure success APS rate, which was MR reduction 2 plus or less. Follow-up time points were baseline procedure, discharge, 30 day, 20, and 12, 24, and 36 months. So the primary objective of the patient analysis is to report on the one-year clinical outcomes associated with MitraClip device from subject enrolled in the Japan post-market surveillance study. Study population at baseline was 500 patients, discharged alive 483 patients, and 30-day visit data was obtained from 458 patients. One-year visit were 391 patients. The overall cohort was elderly, 77.9 years old, and with 65.2% of patients and 58.8% of male gender. And STS replacement scores were 11.95 and very, very high risk. The etiology of MR was functional in 71.6 percentages. The comorbidity profile of the subject included 60.8% of atrial fibrillation, 49.1% of renal failure, 25.1% of primary myocardial infarction. In TTE data, EROA was 0.4 centimeters square, regurgitant volume was 58 millimeters. Ejection fraction was 46%, but the EF was higher in DMR compared with the FMR. The NYHA functional class status profile showed the majority of subjects were class 3 or 4. So the acute procedure success was 91.13%, and the 30-day SLDA was 1.21%, which is comparable to other large-scale registries. Among the more etiology, APS rate and SLDA rates were better in FMR compared with DMR. So procedural outcomes. Number of clips implanted per patient, one clip was 50.5%, and two clips were 42.8%. And the average number of the clip per procedure was 1.46. Implant success rate was 99.4%. Hospital stay was 20 days, a little bit longer compared with other studies, and the mean time of post-procedure ICU stay was 76 hours. So learning curve analysis. Comparison between the first 250 and the second 250 subjects demonstrated significantly shortening the total device time and the procedure time. Learning curve per site experience, total device time and the procedure time also significantly improved in more than 6 cases experience. Especially, early procedures were longer as they had similar effectiveness and safety as compared with later procedures. This panel shows MR severity and severity change and durability. Compared with baseline, the degree of MR was significantly decreased and durable through 1 year with 88.1% subject at MR2 or less. MR severity was analyzed according to the theory of MR. The MR reduction to or less were achieved at discharge and maintained 83.1% and 19.1% in both primary and secondary MR. So this is the 1 year estimated curve and adverse event outcomes. 1 year mortality was 50.9% of all cohorts. Compared with other registries, the 1 year mortality is almost same and comparable. Adverse event related deaths was 14.9% at 1 year and comparable TVT registries. So this is the estimated curve of heart failure hospitalization after MitraClip. Heart failure admission rates were 32.2%. Prior heart failure rates within 1 year before MitraClip was 64.1%. It seemed just half compared with the just a half rate in after MitraClip implantation, and it means preventing from readmission of heart failure. This panel shows NYHA class status change through 1 year. Immediately after procedure, NYHA class was dramatically improved and maintained 93% of NYHA class 1 or 2 through 1 year. So now in conclusions, the study represents the first contemporary report of 1 year outcomes in primary and secondary MR patient treated with the MitraClip entity system in Japan under the Japan Post-Marketing Surveillance Study. Procedure durations were longer for initial cases, but decreased significantly after more than 6 cases were completed at the site. Notably, even though the earlier procedures were longer, they had a similar effectiveness and safety as compared to later procedures. MR reduction obtained post-procedure was significant and durable through 1 year. The MR outcomes matched more closely to site-reported data from other studies, TVT MERS as compared to the core laboratory adjustment adjudicated data from COAPT and EXPAND. Significant improvements were seen in the functional capacity, mortality, and hospitalization rate at 1 year. Rates were comparable to or better than the outcome from contemporary MitraClip COAPT and EXPAND study and the TVT and MERS registry data. Thank you for your kind attention.
Thank you, Dr. Shirai. That's a very, very informative and important talk, I think, given the size and the numbers of cases available in one Asian country. I don't think, I mean, we all know that the rest of the Asian countries don't have the same number of cases. I have a question in terms of the learning curve. I suspect that, when I saw that, the procedure time was different between the two, more than 6 or less than 6 cases, but the procedural success did not change much. Do you think that, why do you think that's the case? Is it because of the patient selection or what?
Yes, as you said, maybe we think that at the first case we treated easier patient compared with later, but according to the learning curve, we can challenge a more complex and complex anatomy cases. So the APS rate and SR rate a little bit increased, I think. Yeah.
Thanks very much. Are there questions or comments from the other panelists?
Can I have it? question, I think I agree with you, and I in our hospital also the bus time is decreased in the experience because the grasping is better than the initial cases. So and also the clip rate is decreasing. So the better grasping allows sufficient treatment with fewer clip and to avoid complication, I think.
Yeah, that's great. Yes, I exactly agree with you. And also the maybe the not only the operator, first operators, but echo operator also familiar with the imaging, familiar with the showing the imaging and effective imaging. So maybe also the operators and imaging specialists also have an experience and decreasing the time.
Yes, completely agree with you. And TEE in the MitraClip is completely different from the surgical mitral valve repair. So in initial case, I was very confused, but it's very important point, I think.
Even your very potent and great operator, even great operators, and maybe confused.
I
for
have
the first group. Yeah.
Slightly different question. I noticed that you have continued with ICU stay. Has that changed in for all of you that are very experienced operators?
Oh,
do you still put patients in the ICU?
Now no in ICU at all. High K unit only 1 day within 24 hours.
Yes, I think that's our experience too. I think at the beginning we were also putting patients in the ICU and for 1 day, but now they go to high dependency, largely because of access issues and making sure there's no bleeding. And but I noticed that in the US there have been papers published on same day admission, same day discharge post MitraClip. I don't think I'm that brave yet, but some of them are really doing it.
Yeah, but there are some political reasons because the not yet the MitraClip was involved in the 何でしたっけあれって包括のやつって。total cost is not packages to cost. So at first, from the US and the other countries criteria, it will fixed to the US style. But so we at first we stayed longer compared with nowadays. Okay. Thank you very much.
Thank you. Takashi, any comments?
For running cover, I totally agree with Dr. Shirai and Izumi and KK. So, and I think one more point is I think we have a very systematic training course, and through that course we can share some complex cases and experience. I think that's is one reason for that learning cover result.
Thanks very much. I think we are. It's time for the next talk. Takashi, would you like to introduce?
Sure. Move to final presentation. The final presenter is Dr. Izumi. He's from Department of Cardiology, Sakakibara Heart Institute. Could you start your presentation?
Thank you, Dr. Matsumoto and Yeo. And I would like to do my presentation, start presentation. Can you see my presentation?
Yes.
So I'm very honored to present here. And I would like to talk about the tips and tricks for MitraClip for interventional echocardiologist. And it is important to determine whether the region is suitable or not for MitraClip, and improvement in procedural technique and intraprocedural imaging expand the indication of MitraClip. And the beautiful image and accurate analysis makes good treatment. So this is my 10 tips and tricks. The first is the case selection. In MR, patient with MR due to prolapse, the segmental lesion is ideal, but severe myxomatous change is challenging for MitraClip. And location pathology does not matter, but independent commissure regions are challenging. And functional MR tend to be a good indication for MitraClip, but MRs with large gaps, deep tethering, short posterior leaflet, and calcification are often challenging. And cleft or deep indentation are likely to cause residual MR. And adequate mitral valve orifice is needed. Mitral valve area needs more than 3.5 centimeters square. And in rheumatic valve disease, there is commissure fusion and leaflet is retracted, and therefore MitraClip causes severe mitral stenosis. So it's challenging case. And understand that device is very important for also for echocardiologist. 7 mm leaflets insertion required to stabilize the clip. And understand how the device moves by the knobs and call instruction in operation with an accurate echo image. Understand and explain the operation required to make the shaft perpendicular to the annulus. So third point is 2D echo. Accurate commissure view and LVOT view is very important. I search accurate commissure view with live 3D mode and turn the probe clockwise to counterclock. And here's a commissure line in this angle. So here's a accurate commissure view in 2D. So 2D and 3D imaging is also important. And long axis LVOT view is perpendicular to commissure view. And the fourth point is 3D analysis for TMVR MitraClip planning. In this case, P2 prolapse. And there is a large gap in A2 P2 lateral. So the clip plan is 2 clip in A2 P2. And first one is lateral and the second one is medial. First one is medial and the lateral is lateral. And in this case, with functional MR with significant mitral annulus calcification, and leaflet calcification also in A2P2 lateral, so plan is 1 clip in A2P2 medial. This is the case. Left slide is pre-clip mitral regurgitation in 3D color, and the right slide is post-procedure. 1 clip is in A2P2 medial and good treatment. Also, there is calcification, but a good treatment. Good, And the fifth point, the preparation before intraoperative TE. This is a building workspace for me. And to judge by combined echo and CNA and hemodynamics, I can see CNA and echo and hemodynamics in TE. And usually TE is performed in left lateral decubitus position. However, TE during MitraClip is performed in supine position. So the appearance may change. So first, check the atrial septum and the mitral valve are clearly visible. Posterior wall of atrial septum are often invisible due to acoustic shadowing for vertebra. So this is intraoperative for an ASDO. If not enough, place the patient in the semi-left position and the posterior wall can be visible. And the sixth point is proper septal puncture. often the highest point from annulus is mid-posterior, and ideally 40 to 50 millimeter from the annulus is needed. And orientation of the clip is critical, so that you orient the clip above and below MV leaflets. At the A to P2 position, the orientation of the clip should be 12 and 6 o'clock on MV end-face view. And finally, check the orientation after grasping. It is a very important point. And in this case, there is a MR with A3PC Prolapse. So we performed MitraClip with 2 clip. And the orientation in this case is 11 and 5 o'clock. And this is a new onset MR by distortion of leaflets. After first clip implantation, new MR in A1P1 by distortion of leaflets. In LD side view, first clip grasped A to P2 center to lateral and P to medial. So the anterior leaflet was pulled towards medial side and a gap was created in A1P1. It is more important in XT and XTR and XTW long device, I think. And the S point is the final check leaflet insertion. Observe in detail and record all of time the gripper down onto the leaflet until the clip partially closes, and leaflets and gripper and bouncing on the clip arms. And good insertion makes less lift insertion, leaflet motion. So 9th point, residual MR, it is complex. And this is the criteria for residual MR to be mild or less as follows. It is important to set treatment goals before procedure and share with team. And I think in the TMBR operation, T is called as the eyes of a heart team. But also I think the echocardiologist is mouth of a heart team, because it is important to keep speaking live with the treatment process and share the information with the team. So this is my T tips and tricks for MitraClip for becoming a reliable imaging specialist. Thank you for your attention.
Thank you very much, Dr. Izumi. Echo is very key for success of MitraClip program for sure. So my question is, I know you are very skilled, experienced echo doctor, but as you said, echo of MitraClip is different from mitral valve surgery.
Yes,
so
that's right.
How did you improve your skill and knowledge about MitraClip? And second one, how did you educate your interventionalist about echo knowledge?
But the most important point is learn from the experienced operator or institute. I learned from Dr. Isotani of the Kokura Memorial Hospital and Dr. Izumo in St. Marian Hospital. The both of echocardiologists is the best echocardiologist in Japan, I know. So I learn and everything and from to echocardiologists. So because and I always go to a surgical MV-plasty intraoperative echocardiology, but it is completely different from MitraClip. So, and I'm learning from fast the 0 point.
How about education for interventionalists?
So the interventionist, and not all interventionists know everything about mitral valve anatomy. So discuss and in detail before the operation to the for about the etiology or anatomy and the goal and then share with team. It is a very important point, I think.
Yeah, I agree. I'm interventionalist, so for me, it is very important to discuss with echo doctor with using a same language, I think. So is there any question or comment from panel or KK?
I have a question regarding, you know, the echo evaluation for making the valve too tight. So one of our biggest challenges is that, you know, increasingly we are seeing older and older patients, and I'm always really fearful that the clip has captured too much of the leaflet, and there is strain on the leaflet. Is there any way on echo that you can advise that there is too tight? There is
Yes,
the gradient is okay, but I'm just saying too much of the leaflet.
yes, I have experienced such thing, and we perform the MitraClip for an atrial function MR, and the first clip and put in the A to B medial, and the moderate MR residual MR is lateral position, so second clip in A to B to lateral, and the annulus is hinged in the second clip, and my mean gradient up increasing to 6 millimeter mercury. So we always full close the clip, but in this case, we a little open, and the gradient is a little decrease to 4 millimeter mercury. But I don't know it is correct procedure.
So about complication, there are several complications during MitraClip, but the leaflet tear is very difficult to avoid because it is very difficult to assess the fragileness of leaflet. Do you have any comment about how to assess the fragileness of leaflet to avoid leaflet tear?
I think, and it is important to the anatomy and etiology, and especially infective endocarditis is a very fragile mitral valve, so avoid IE. And in the very elderly people, the valve deterioration is very severe in some case, and we sometimes can't analyze this is a leaflet or a code, because the code is thick and calcified. So, and if there is a large gap in the annulus plane, anterior to posterior, when we sometimes avoid this case.
Thank you very much, Dr. Izumi. Then now time to close this session. KK, could you close the session?
Thank you, Takashi. So thanks very much to everyone for listening to this session. We have learned a lot from our speakers today. Dr. Takashi Matsumoto shared on the APSC MitraClip consensus document. We heard from Dr. Shirai on the Japanese experience with the MitraClip after its launch in 2018. And lastly, we heard from Dr. Izumi on some of the TE tricks for the performance of the MitraClip procedure. And yes, I did speak on some of the latest data that we have on the MitraClip procedure in the world over the last 1 or 2 years. So with that summary, thank you very much to everyone for joining this session. Thank you to my co-chair as well as our distinguished speakers, and I wish all of you a very good weekend ahead. Thanks very much, everyone.
Thank you.
Thank you.